Hi, my name's Dipak Kotecha. I'm a professor of cardiology at the University of Birmingham in England. I'm also chief investigator of the ESC STEEER-AF trial, which I'll be talking today about the clinical outcome analysis. So STEEER-AF is a pretty unique trial. It's the European Society of Cardiology's first randomized clinical trial and was designed to run in parallel with changes across the European Society of Cardiology's guidelines in atrial fibrillation. So I also was a chair on that guideline with my colleague Professor Van Helder, and we designed the STEEER-AF trial to really look at how we could take guideline adherence, improve it, but importantly look at whether that impacts on outcomes for individual patients. So STEEER-AF was really designed to look at whether we can educate healthcare professionals better. That could be doctors, nurses, pharmacists, allied health professionals, anyone who's working in the field of atrial fibrillation. Can we educate them better and then get better patient level outcomes? So can the patients be more adherent to the clinical outcomes, to the guidelines that we're looking at? And that was the kind of the core structure of that. So we designed an education program through the European Heart Rhythm Association and the ESC, which was initially going to be a hybrid type of approach. But of course the pandemic came along, so we had to review that and turn it into an online program. But these were also helped by national trainers in each of the countries, so that the learners from each of those centres that were randomised to the intervention could benefit from kind of ESC education around how to get guideline adherent care for their individual patients. We were able to recruit over 1,700 patients from 70 centres across 6 countries in Europe. And that was really due to the massive efforts across all of those countries and the ESC staff and obviously clinicians all around those countries. So it was a huge global effort to look at guideline adherence. The 1,700 odd patients were looked at about their adherence to guidelines at the beginning of their trial entry. And then the intervention happened in half of those centres. It was a cluster randomised trial. And then we looked further on, 6 to 9 months after those centres were randomised, whether the patients were adherent to guidelines or not. That formed the primary analysis for STEEER-AF, which was presented at last year's ESC Conference and has been published as a Nature Medicine paper. In this late-breaking conference, we're looking at the clinical outcomes, which happened roughly 18 months after those centres were randomised. So on average, around 2 years from each patient's original baseline visit. That was an exploratory analysis, but that's the aim of this particular late breaking, to update on whether those guideline changes actually had impact on longer term outcomes for those patients. So of those 1,700 patients, over 94% of them we had outcome data on, which is a huge amount of work, and thanks to all of those staff team members, we had thousands of people working on this trial across all of those countries. So of those patients, we saw that there were levels of outcomes that were related to guideline adherence. So if we look at, for example, stroke prevention guidelines, in the patients that were fully adherent to stroke prevention guidelines, they were significantly less likely to have the composite clinical outcome, which included mortality, stroke, transient ischemic attack, different types of emboli and hospitalization for heart attacks and heart failure. So in that group, there was almost a 33% reduction in the events if those patients were guideline adherent to the European Society of Cardiology guidelines. Now that didn't occur in the rhythm control analysis, but that was partly expected. Most of rhythm control is about symptom control rather than about clinical outcomes, and it confirms really what we wrote in the 2024 ESC-AF guidelines. The rhythm control is predominantly for symptom control in patients. Of course, there are some select groups where there is prognostic improvement, but we didn't see that in the clinical trial. So that was the kind of guideline adherence part of the question. We then went on to look at whether the intervention, so giving education to your healthcare professional, could influence the patient's level of outcomes. Now, of course, important to state that was an exploratory outcome. STEEER-AF was not powered to detect any significant changes there, but we did see in those centres where they had the education intervention, that those patients did better. Now, numerically, they had an event rate of 7.2% compared to over 9% in the centres where those physicians hadn't had that education. Now, if you look at the Kaplan-Meier curves, this kind of event rates, they diverge right from the beginning, continue to diverge. Now, they didn't reach statistical significance. We weren't expecting that. But there was a clear separation, which is suggestive that potentially these sorts of approaches in the future, if they're confirmed in future trials, could be used to prevent hospitalization for patients with atrial fibrillation. So the first thing to say is that clearly guideline adherence is important, and particularly for stroke prevention, we've confirmed that if patients are fully adherent to guidelines, they will have lower rates of outcomes. The question, of course, is how you achieve that. Now, we think in STEEER-AF that was partly to do with the education. Of course, further trials are needed to confirm that. But it's worth remembering that in Europe, around 80% of the cost for AF is around hospitalization. And in particular, the intervention seemed to have a benefit on rehospitalization. So if that can be confirmed in future trials, then it could open up a huge opportunity to improve the care of patients, but also reduce the burden that AF has on healthcare services. And of course, this was a very big collaborative effort across all of these countries, and it goes to show really how such an effort at sort of individual hospital levels can have effects that will transcend the project and hopefully lead to future guidelines that are written better so that patients can improve not just for AF, but of course for other cardiovascular conditions.